This is going to be the section on ECG monitoring for paramedic cardiology. We often refer to electrocardiogram as an ECG. Some people refer to it as an EKG. All those terms are interchangeable. But basically what we're doing is we're obtaining a graphic representation of electrical activity in the heart. Please remember that we're only seeing the electrical activity and not the mechanical. The only way we can determine if there is mechanical that is associated with what we're seeing is by checking the pulse and making sure that that matches what we're seeing on our monitor. EKG machines offer different views of electrical activity. We're going to be talking about those. And we're going to be talking about exactly how electrodes transfer that signal to us. So basically we hear, we refer to it as a 3-lead, okay? And the 3-lead is the standard from your limb leads. You'll hear people refer to it sometimes as a 4-lead because we now have a limb lead for all 4 leads. And if you're in the ER in-hospital setting, you'll see a 5th lead placed in the center of the chest. However, we're still getting the same views. We're just dealing with a variation in current to obtain those views to make them a little more accurate. Also, please keep in mind that whatever machine you're using uses filters to it decides what it feels like you need to see, what's important. So most of these machines are not in true diagnostic mode because of the artifact that will be associated with that. So anyway, we have on a 12 lead, we have 3 standard limb leads, leads 1, 2, and 3. We'll have our augmented limb leads. That's going to be AVR, AVL, AVF. And then obviously we'll have our precordial or ventricular leads, which are V1 through V6. And each lead assesses the activity in the heart from a different view. So let's talk about the planes. Our limb leads get views from the frontal plane, okay? So you can see from the diagram that that is the up and down portion. It is looking at the heart vertically. However, our V leads would look at a horizontal plane. When we place our V leads there, it would be looking across the heart. So it's important to know exactly what you're looking at. Our electrode placement for the frontal plane, you see the right arm, right leg, left arm, left leg. They are typically associated with specific colors. You will see your right arm always being white, the right leg always being green, the left arm always being black, and the left leg always being red. You'll hear people say white on the right and smoke over fire as a way of remembering them, but they should all be labeled with letters to let you know specifically where they go. Also, keep in mind that you will see in the in-hospital setting, the correct placement of electrodes would be on the insides of the wrists and the insides of the ankles, with your patient lying very still. However, we may need to, that's to get the biggest picture possible of what's going on electrically in the heart. We may, in the pre-hospital setting, need to dial that in a little bit, bring it to the shoulder, or the upper chest, bring it to the upper thigh or lower torso in order to remove joints from our tracing. When I say joints, I mean like physically our wrist, elbow, shoulder joint, that type thing, because of vibrations that may be all around us from just simply the truck running or anything like that. So you might see a lot of pre-hospital situations where those leads are placed a little tighter. And then we have our horizontal plane leads right here, V1, V2, V3, V4, V5, V6, and they're looking at the cross view of the heart. So standard limb leads are bipolar leads, and what that means is they have a specific positive and a specific negative, and we are looking at a tracing traveling from a negative toward a positive. Okay, so anytime, keep in your mind, anytime an electrical impulse is traveling from a negative toward a positive on our EKG, we have that line, that imaginary line in the middle that we refer to as the isoelectric line, or you hear some people call the baseline. Anything that's traveling toward a positive electrode will be represented in an upright or positive deflection on our monitors. And here's an example. Lead 1, whenever we're looking at lead 1, we're looking at the cross view of the heart going from the right arm over to the left arm. So in this case, the right arm would be a negative and the left arm would be a positive. Remember that just because we put an electrode on, that electrode is not always positive or negative. It is positive or negative dependent on what it's trying to look at that time. Current flows both ways. Then if we're going to our lead 2, which is the one we monitor in the most, because we get a diagonal view of the heart, goes from our right arm down to our left leg. And our right arm, once again, would be negative and our left leg would be positive. However, if we were looking in lead 3, that's looking down the side of the heart. That's looking from the left arm down to the left leg and the left arm, whereas in lead 1, that electrode is a positive. In lead 3, that electrode would become a negative as the electricity is traveling away. And your unused lead in each one of these is actually a ground, just like you have a ground for an electrical outlet. Our augmented limb leads are the same thing, okay? But instead of looking from bipolar or in a bipolar capacity from a negative over to a positive, they actually create a augmented pole that's in the center of the body. They have no distinct pole, and we'll show you on the next diagram. Using algorithms and using current, we have that central terminal right here in the center, and that is what we're seeing. We're seeing from the central terminal traveling to the left arm, that's going to be AVL, toward the feet, that's going to be AVF, and then the right arm, AVR, which we don't use very often because there's not a lot that happens on that right side of the heart that we can typically use in an EKG tracing. And then we have our precordial leads or chest leads, okay? And they are unipolar. They create an imaginary spot at the back of the heart, and they each look, they primarily look at the left ventricle, maybe a little bit of the right at times in like 2-3 AVF. But they are unipolar leads, and they create this. They create an imaginary spot right here, another central terminal, if you will, and they're looking at as that electrical flow travels from each one of those, and that's how we're getting our tracing. So you can see the different views that each one is looking at. So we use cardiac monitoring all the time. Remember that 12 leads are there to find specific problems with the heart. 12 leads are not for rhythm interpretation. I repeat, 12 leads are not for rhythm interpretation. You need a 6-second strip, typically in lead 2, to determine what the underlying rhythm is. We use 12 leads for things like elevation, determining elevation in specific leads to see if we have STEMIs or maybe we have hypertrophy or bundle branch blocks, those types of things. But we are not using a 12 lead for rhythm interpretation. So make sure that you, when you apply electrodes, you put them in the appropriate area. We know that they have an adhesive back on them. You'll get those as a practical exercise in running EKGs on each other. They have an adhesive back. Make sure that the contact with the skin is not overly hairy. It is clean, and that you have you might have to use an alcohol prep to remove dirt or oil for someone in order to obtain a good tracing. You'll put those electrodes on that prepared site. Okay, like I said, remember in hospital you'll see a lot of the insides of the wrists, the insides of the ankles for the limb leads. In the pre-hospital setting, you'll see a lot of torso attachment. So what's going to come out? You're going to print out graph paper, all right? And all graph paper, it doesn't matter. It's made up exactly the same. It's all in 1 millimeter squares, and that's 1 millimeter by 1 millimeter, 1 millimeter tall by 1 millimeter wide. All EKGs come out of their machine at exactly the same speed. The reason being is because we're looking at time as it travels out. And we'll get our measurements for that in just a second. So we're measuring time as our EKG paper comes out, and we measure height or amplitude that determines how much voltage there is. So that's why when we talk about P waves in a moment, they're small because our atria are small, but then we have a QRS complex for our ventricles, and it's much bigger because they're much bigger. So that's what I mean when I say we'll be looking at voltage. So not to get confused, okay, I understand that time is, as our paper is moving out, we look at time moving across, but we measure that by using vertical lines. We see time passing those vertical lines. Voltage or amplitude is measured by traveling up and down, and it's traveling over the horizontal lines, okay? It's easy to get those confused because we think about our EKG paper going coming out of our machine and traveling across, and so we think about across being time, but we couldn't measure time here because if we were going across, because we would have no marks. So remember, time is based on vertical lines, voltage is based on horizontal lines. And they come together to create a grid, okay? And each one of these grids is a 5 by 5 square, okay? Which means that is 5 millimeters across and 5 millimeters high. Over here, the same, 5 millimeters across, 5 millimeters high. And when we break that down, each one of those boxes, and I'll go back for just 1 second, what we're actually looking at is one of these individual boxes in the next slide. One of those 5 by 5 boxes. Each small box, each little 1 millimeter by 1 millimeter, as it goes across, is 0.04 seconds. So that means that 5 of those boxes, or whatever, or each one of the bigger boxes, is 0.2 seconds, because 0.04 times 5 is 0.2. So 0.2 seconds. So we look at it right here, like it down on our strip. This is going to be 0.2 seconds. So that means that 5 of those bigger boxes, 1, 2, 3, 4, 5, would be 1 second, because 0.2 seconds times 5 again is 1 second. Okay, and we can do the math on that. If there's 5 large boxes, if there are 5 large boxes in 1 second, in order to obtain a 6-second strip, we would have to have 30 boxes all the way across, because that would be 5 large boxes times 6 seconds. So 30 large boxes going across is a 6-second strip, okay? And 1 large box going vertically, traveling up and down the horizontal lines would be 0.5 millivolts. So let's talk about the P wave. The P wave is the first positive or upward deflection. At least it should be upward in a normal tracing. The P wave is the first positive deflection on your EKG. Okay, it represents atrial depolarization. So when our atria fire, we see that. Well, I should say fire. When our SA node fires and sends that signal down the conduction pathway, we should see, because it's traveling from a negative toward a positive, we should see a positive P wave. And it is rounding up. They should be rounding up right. Not, but sometimes you will see them be a little peaked. We have a PR interval, and that's from the beginning of the P wave to the beginning of the QRS complex. Okay, very important to remember. PRI or PR interval begins at the beginning of the P wave and ends at the beginning of the QRS complex. And the QRS complex is a larger complex, and it's comprised of actually 3 different waves. It has a Q wave, an R wave, and an S wave, or ideally it would. And by definition, the Q wave is going to be the first negative deflection after the P wave. Q wave is the first negative deflection. The R wave would be the first positive deflection after the P wave, and the S wave would be the second negative deflection. So we have, well, let's move on a little bit. We can see lots of different configurations. If we had a P wave here, this is a standard. We have a first negative deflection in our Q wave, first positive deflection in our R wave, second negative is our S wave. But we always refer to it as a QRS complex, but just note that it doesn't always contain all 3 waves. We would still say, oh, we're looking for the QRS, and we might see this where it only has a Q wave and an R wave, or the same here. Oh, what about the QRS complex? But this one is only an R and an S. The ST segment represents the early phase of repolarization of those ventricles, okay, and it immediately follows the QRS complex and goes until the T wave begins, okay. So the ST segment is between the QRS complex and the beginning of the T wave, all right, and the point in which it takes off from the QRS complex, that's called the J point, and we'll see that later when we start using or doing rhythm interpretation. And the T wave's last part of our standard EKG, and it represents the repolarization of the ventricles, okay? It's typically a little bigger than the P wave. Sometimes it might be a little pointed, but usually not much. Most of the time it's going to be rounding up right a lot like a P wave, just larger. So remember that the P wave is the atria depolarizing or firing. The QRS is the ventricles depolarizing or firing, and the T wave is the ventricles reloading or repolarizing. We don't see the atria repolarize because remember they're much smaller than the ventricles, and theoretically they are repolarizing or reloading at the same time the ventricles would be firing, and so we lose that in the tracing. It's hidden by the QRS. And then we have the QT interval, and the QT interval is measured from the beginning of the QRS to the end of the T wave. Okay, so we got our PR interval, beginning of the P wave to the beginning of the QRS, the QT interval, beginning of the QRS to the end of the T wave. And that represents time from the beginning of ventricular depolarization until the end of repolarization. Basically, the time it takes everything to fire and reload. Also note that we can get artifact on our monitor. That's basically our baseline becomes unreadable, untraceable. We have different, it comes from different places. It could be our patient shivering, could be the truck running, could be electrode falling off, anything like that. So we do everything we can to make sure we get as tight a tracing as possible, as clean a tracing as possible. Our monitor helps us out with that with filters, but sometimes we might have to move electrodes or change our procedure a little bit. And there we go. Here are our measurements, and you want to definitely commit this to memory. Okay, a P wave is right here. That is our atria depolarizing. It's rounding up right. Our PR interval, okay, from the beginning of the P wave to the beginning of the QRS should be 0.12 to 0.2 seconds. Okay, and that means 3 to 5 small squares. All right, that's 120 to 200 milliseconds. Our QRS should be 2 to 3 small squares. You'll see some texts that say that the QRS should be 0.10, okay, or 0.10 milliseconds, and anything 0.12 or wider is wide. We typically go with 0.04 or 0.08 up to 0.12 as our range, okay? So a QRS, that's the standard width, 2 to 3 blocks, 0.08 to 0.12. Sometimes you will see them as thin as 1 block, and that would be 0.04, but anything greater than 0.12 is considered a wide QRS, okay? And then we have our ST segment and our QT interval, and that could be 0.10 all the way up to 0.25, and up to 440 milliseconds may actually be considered normal, dependent upon your patient. So let's talk about interpreting a rhythm. All right. Pause right now from your the slides and think about what we're going to be doing. We're going to be determining what's our rate, is our rhythm regular, if we have P waves, if we have QRS complexes, what the relationship between those are, and if we have any ectopic beats. So those are the things we're going to be working. Okay, so the questions you're going to have to ask yourself is, if this patient sick? Okay, are they symptomatic? Do they seem stable? What's their heart rate? Are their QRS complexes normal at that 0.08 to 0.12? Okay, or are they wide? Are their P waves normal? Are they present? Are they upright? Is there one between for every QRS complex? And are there any extras? So you have to analyze the rate. All right, analyzing the heart rate can be done in a couple of different ways. We're going to talk about 2. The first way we would do it, paramedic math in the pre-hospital setting, is you count the number of QRS complexes you have. Okay, that's quick math. The number of QRS complexes in a 6-second strip multiplied by 10 gives you an average heart rate. Okay, it is not specific, it is a generalized heart rate. So if I had a 6-second strip, and in that 6-second strip I had 7 QRSs, I would say 7 times 10, and I would have a heart rate of about 70. If I had 14 QRS complexes in a 6-second strip, I would multiply that times 10, and I would have a heart rate of about 140. The most accurate method we can use in the pre-hospital setting, though, is to count the number of small, those 1 millimeter by 1 millimeter squares between 2 R waves, and divide that into 1500. So if I had, excuse me, if I had 15 blocks from R to R, measured my R to R, 15 small blocks in between each one, I divided 1500 by that 15, my accurate heart rate would be 100. Now we want to know if the rhythm is regular or irregular. How do we do that? We compare R to R intervals. We just basically count the small number of blocks, and you can use calipers to do this. You can use a, for those of you who don't know what calipers are, I'll show you in a second. You can use a piece of paper, marking, placing down on your, and making a mark at 2 consecutive R waves, and then moving that down to see if they line up where they're supposed to. But that's how we're going to determine our regularity. We place the tip of a caliper at the peak of 1 R wave, and then we move it to the next R wave, and then we want to make sure that that distance is the same. So if I were counting the small blocks, I would look here and I would say there are 21 blocks here from R to R. There are 21 blocks from R to R here, another 21 here, and another 21 here. And it's important in rhythm recognition to not just count one, to count multiple. The more data we get, the more accurate our interpretations can be. So this would be considered a regular rhythm, as it had the same number of small blocks from R to R, or the R's were the same distance from each other. However, an irregular rhythm from R to R here, we would see we have 20 small blocks. When R to R here, we have 17, here 15, here it grows to 27, here it grows to 23, and we do those numbers, and we do write those numbers down because we could see a pattern in the irregularity. If it was like 20, 17, 15, 20, 17, 15, 20, 17, 15 over and over again, it might be irregular, but it would be regularly irregular because it had a repeating pattern. However, here we have no apparent pattern, and so we would consider that irregularly irregular. And these are those calipers we were talking about, how we're placing them on our R wave to R wave, or right here, they're lying there at the bottom of the, or the top of the beginning of the S. But you set them, you measure from complex to complex. And then you're going to analyze that QRS complex. You want to make sure that it's less than 3 blocks wide or less than 3 teeny squares, okay? So it's nice and narrow in that, within that range of 0.08 to 0.12. And once again, there's various QRS configurations. Now we're going to analyze our P wave. We want to be round and upright. Okay, there should be a 1-to-1 relationship with P waves to QRS complexes. I'm going to explain that in just 1 second. We should have P waves should have a standard morphology, or they should all be the same shape. Okay, them being different shapes can indicate different things as far as our interpretation is concerned. And we want to look at our PR intervals and make sure that that PR interval is consistent. So once again, we don't just look at one, we measure PR interval after PR interval. So a normal P wave looks like this. And then we, and just like Sam, we just talked about the PR interval, sorry, and how it is 0.12 to 0.2 seconds, or 3 to 5 1 by 1 millimeter blocks. So here are your 5 steps. Okay, remember each P wave is atrial depolarization, QRSs are ventricular polarization, the ventricular repolarization is represented by the T wave, and all QRS complexes should be represented by P waves, and we want to make sure that it's regular. Now, the questions I ask myself when I do rhythm interpretation in specific order are this, and they don't necessarily go in order with the slide, although the information is on there. The very first thing I want to know is my rhythm regular? I'm going to measure R to R, R to R, R to R, all the way through and see if that number is the same. If that number is the same, then I know that I can calculate rate based on the number of blocks in between my R to R. If there's difference, I may have a range in rate. Suppose I had a patient who was in AFib, who was very irregular. We know that if you'll see that when you place patients on a monitor and find that they're in AFib, you'll see the rate constantly changing. So by taking that regularity, I could take a small number and a big number, and I could actually calculate a range. But that's for down the road a little bit. I want to know, is it regular? I want to calculate my rate. Then I want to know, do I have P waves? Are my P waves round and upright? Do all my P waves look the same? I'm going to skip over to QRS complex. Do I have QRS complexes? Are my QRS complexes nice and narrow? And do they all look the same? Is there a P wave for every QRS complex? And if there is, I want to know the relationship. That's my PR interval. I'm going to measure my PR interval on multiple complexes to make sure that that PR interval is staying the same. So the very first thing I did was I checked, is my rhythm regular, by counting the blocks in between R to R. After that, I calculated my rate. That would let me know if I had a slow rhythm, a bradycardia, a fast rhythm, a tachycardia. I want to know, were there P waves? Were they round and upright? Did they all look the same? I want to know, did I have QRS complexes? Were they nice and narrow at 0.08 to 0.12 or 2 to 3 blocks wide? And did they all look the same? I want to know, was there a P wave for every QRS complex? And if so, the relationship between the two. What was the distance of my PR interval? And does that distance change from complex to complex, or does it stay the same all the way through? And then I also ask myself at the very end, do I see any ectopic beats? Ectopic beat is simply something that's somewhere it's not supposed to be. That's what ectopic means. Do I see anything unusual? Do I see a rhythm that appears regular all the way through, but then it looked like something happened early and it might be a premature thing? Okay, so ectopic beats, does anything stand out, would be the last thing I would look at. And that is rhythm interpretation. P waves, QRS complexes, T waves, and their relationship to each other and what they represent.